Here we present a complex case of a patient who presented with a tandem occlusion at the cervical internal carotid artery and middle cerebral artery. He was treated with carotid artery stenting, followed by mechanical thrombectomy with stent retriever. The patient is a 52-year-old female who presented to the emergency room after waking up, presented with right facial upper and lower extremity weakness. Her initial NIH score was 12. She had significant past medical history, hypertension, atrial fibrillation, and coronary artery disease. She did not qualify for TPA. Computed tomography was normal. However, CT angiography demonstrated complete occlusion of the left internal carotid artery and middle cerebral artery. And CT perfusion also demonstrated significantly increased time to peak on the left hemisphere with very good volume preserved. The patient was taken immediately to interventional radiology for revascularization of the left internal carotid and middle cerebral arteries. Under conscious sedation and through a right femoral artery approach, we put a 9-French femoral sheath and navigate a balloon guide catheter to the distal common carotid artery. Perform an angiography demonstrating the left internal carotid artery occlusion. Under flow arrest, you can see how the balloon is inflated, causing flow arrest. We navigate a intermediate catheter, a microcatheter, and a microwire. The purpose of this triaxial system it gives support to the microcatheter and microwire and explore the carotid artery to see if there is patency distally. So we are navigating the microwire microcatheter successfully through the internal carotid artery. We feel no resistance. This is another catheter, and we are performing an injection here, demonstrating that there is an occlusion somewhere in between the internal carotid artery bifurcation and the distal segment. So first we fix the extracranial carotid artery stenosis. By doing that, we first deploy a distal filter. This is to protect from distal emboli, from the carotid angioplasty. We then pass a stent. We always try to use a long stent. In this case, it's an 8x36 wall stent, because we don't really know exactly the length of the stenosis, and we want to cover the entire carotid artery if possible. And you can see as we deploy the carotid stent how the stent is narrow at some point. So once we have revascularized the extracranial carotid artery, we maneuver a triaxial system form of aspiration catheter, microcatheter, and microwire through the stent. So here we are also maneuvering the guide catheter through the proximal portion of the stent. Now we are navigating the aspiration catheter, and we would like to bring that up to the MCA. Therefore, we need more support and advance the guide catheter even further. Once we have intracranial access, we obtain a roadmap, perform a roadmap that demonstrates where the occlusion at the proximal M1 segment of the middle cerebral artery is. We then cross the thrombus with microwire and microcatheter, trying to keep a J shape on the microwire to prevent any possible perforation. Also bringing the aspiration catheter as proximal as possible. Here we're turning around the siphon turn. Perform a microinjection to make sure that we have crossed the entire length of the thrombus. Remove the microwire in exchange for a stent retriever. We then carefully deploy the stent retriever along the MCA and remove the microcatheter entirely. We then wait for several minutes for the thrombus to be in good relation with the stent retriever. Bring the aspiration catheter as close as possible to the stent retriever, and this is the Solumbra technique. And under direct aspiration from the intermediate catheter, we pull the intermediate catheter and the stent retriever simultaneously. We then perform a intracranial run demonstrating complete revascularization of the internal carotid artery and middle cerebral artery. Thank you.